Good afternoon and welcome to Facebook Live. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. Today is April 13th, 2023. Thanks for taking the time to either watch this live or watch it at some other point in time. Looking forward to our conversation today with Dr. Charles Sweeney, who is a nephrologist, actually he's part of the group of Rockford Nephrology, who comes to CGH to help us see patients, help see patients for us here at CGH. Dr. Sweeney, as a nephrologist, does a lot of work with, of course, kidney issues, but also people's blood pressure. So really looking forward to having a chance to ask him some questions today. So without further ado, let's get Dr. Sweeney on. Hi, Dr. Sweeney.
Hello.
Thank you for taking the time to answer a few questions for us.
Sure, glad to be here.
Yeah. So Dr. Sweeney has been, even though he's on our medical staff at CGH, and even though he doesn't work for CGH, has been coming to CGH for a long time. How long have you been coming here, Chuck?
Oh, probably about 25 years.
Okay. Yeah.
Long time.
So yeah, he's a fixture.
If I'm not here, one of my partners is. So
that's right.
Every week, Monday through Friday, we're here. We see outpatients. We see patients in the hospital, consultations, and we see patients at the dialysis unit in Sterling.
Yep. So a big part of our community's healthcare. So, all right. Well, you ready to try to take a crack at a few questions about blood pressure? Yep. Okay. All right. And we will have a few bonus kidney questions at the end.
Okay.
But we're going to start with blood pressure. So, all right, let's talk about just first of all, hypertension and how to prevent it in the first place. So what suggestions do you have for folks if they just don't want to get hypertension to begin with?
It's a great question. The best way not to get it is to avoid getting it. Probably, some relatively simple things to do once you're motivated to do it is regular exercise to, get your heart rate up. It helps to keep the elasticity in your blood vessels so your blood pressure doesn't rise. Exercise, low salt diet, low fat diet, weight reduction or not gaining weight to start with. Those are all things that would help to prevent the development of hypertension.
Good. And I should go back to even the question before that would be like, can you define hypertension?
Sure.
And like what causes it?
Right. The heart pumps blood. It pumps blood through one big contraction and then it relaxes. So we measure the blood pressure as the pressure that the heart builds up when it pumps blood, so that the blood pressure is recorded in two numbers, the top number or the systolic number, and then the bottom number or diastolic. So you can picture the heart contracting and pumping, building up pressure. It contracts. That's its highest pressure point. That's your systolic blood pressure. And then it relaxes before it starts to contract again. And the pressure that it relaxes to, the lower number, is your diastolic pressure. So we're all used to hearing our two numbers when we have our blood pressure taken, the systolic and the diastolic. Hypertension is usually, there's some variations in how it's defined, but it basically is defined as having a systolic greater than 130 or a diastolic greater than 80. So if your blood pressure top number greater than 130, bottom number greater than 80, then, and not just for one reading, but for a series of readings or consistently your blood pressure is higher than that, then we say that you have the diagnosis of hypertension. There are some variations in the numbers to various medical societies and things like that vary the number a little bit. But just to keep it simple for everyone, let's just say that 130/80, higher than that consistently is what we would define as hypertension.
Okay. Do you give any, you let that slide a little bit or go a little bit higher if someone is getting older?
They're getting older, maybe a little bit. We used to think that blood pressure in elderly people was not that important to treat, but we know that especially systolic blood pressure, there's a big study done about 20 years ago that showed us that treating hypertension in the elderly, I probably once you're above 60 or 65, we maybe let it slip to 140 or so, the top number. But then we do think that treating hypertension in the elderly is very important, though.
Yeah. Which kind of goes to, I guess, the next question I was going to ask, and just why is it important to try to control your blood pressure as best you can?
Well, it's crucial because, as you've maybe heard before, or the audience has heard, hypertension, high blood pressure is the silent killer. In other words, you don't know you have it. And the only way you know you have it, it's not like having a rash or vomiting or having a tummy ache. There's really no symptoms of it. And the only way you know you have it is by getting your blood pressure checked with the cuff that we're all familiar with, either an automated cuff or a cuff that then is attached to a stethoscope, and we get a reading from that. So it is important to have your blood pressure checked. It's the silent killer. There's no symptoms from it. Having high blood pressure, it increases our risk of a lot of other diseases, such as heart disease, having a heart attack, having what we call congestive heart failure, which is sort of an advanced form of heart disease, having strokes, having things like that. So having vascular disease or clogging of our blood vessels in our legs that can affect our ability to heal wounds in our leg and our ability to ambulate and walk as far as we want. And then also in the big blood vessel that carries blood from our heart to the rest of our body, the aorta, we don't want that to get clogged with the effects of high blood pressure and high cholesterol. So controlling blood pressure is really important.
It also has a little bearing on your kidneys too, right?
Yes, it does. High blood pressure causes kidney disease. Kidney disease can cause high blood pressure and make it worse. So in people who have chronic kidney disease, CKD, we really emphasize blood pressure control. It helps your kidneys to last longer. It can help to prevent you from getting chronic kidney disease.
Yeah. I've read off and on in the medical journals over the years, salt, and whether salt is a big deal or not a big deal for some people, not for other people.
Right.
What's the latest medical understanding of that, Chuck?
It is for some people and it isn't for other people. You can't really tell who's who. So we just encourage everyone with hypertension to follow a low salt diet. That would be a 3 or a 4 gram sodium diet. That is what the USDA puts on labels for us. If you see something and it says that it gives you 10% of your salt for the day, it means that it gives you 10% of a 4 gram sodium diet. So we encourage people to limit the salt in their diet, limit the sodium. It's the first step in trying to treat high blood pressure. If we want to try treating it before we put somebody on medications, for instance.
How long, like ballpark, how long would you have to restrict or try to be careful with your salt intake to see if you're salt sensitive, to see what that's going to do for your blood pressure? And how much would that change your blood pressure if you were salt sensitive and you were better about what you ate?
I would say that it could I would say the first part that we would want you to try limiting your salt for, let's say, 3 to 4 weeks, and that we would hopefully get a 10, maybe 20 degree drop in your blood pressure readings, maybe 10 to 15.
Okay. Systolic points or just percentage?
Systolic points. Yeah.
Wow, that's pretty impressive. If you're salt sensitive, that's a big deal.
Yeah, if you're salt sensitive, right?
Yeah. Okay.
It's hard. Let me just say this though: it's hard to do, very hard, because, as you know, salt is in everything. And it's in every kind of preserved food, every canned food, every frozen food, fast food, snack foods, restaurant foods. It's everywhere. I mean, I have some patients who say, the only way I know how much salt I'm getting, I make everything from scratch, and they literally do, so that they can control precisely how much salt they put in their diet.
Yeah. Okay. And I was curious too. I mean, you can do all the right things and still have high blood pressure. So can you talk a little bit about what percentage of us have high blood pressure as the years go by?
It's pretty high, actually. At least 30%, maybe 35% of Americans have hypertension. As we age, we become more vulnerable or more susceptible to having hypertension, especially as we get up above, 55 years old. So it is very common. Like I said, it frequently goes undetected because you do have to look for it in order to find it. The other things that can tend you towards getting high blood pressure are if you're obese. So we look at that number called the BMI that we see, which is calculated off of your height and your weight and your body habitus. And if your BMI is, for instance, when it starts getting, in the high 20s, even the mid 20s, that's a warning sign that, weight reduction might be in your interest to prevent hypertension. There is a very strong family history or preponderance of high blood pressure. So if your parents had it or have it, if your siblings do, guess what? You probably are going to have it too. So family, age, weight, also your race, more common in African Americans than it is in non-African Americans. And also in African Americans, it tends to be a little worse, a little harder to control. And also, especially in terms of kidney disease, can prone you to developing kidney disease more so if you have uncontrolled hypertension and you're African American than if you're non-African American.
Okay. How about medications? Are there any medications you see patients commonly taking that can contribute to causing their blood pressure to rise?
Sure. So a biggie that people have access to is over-the-counter cold remedies that have pseudoephedrine and phenylephrine in them. So you would have to read the label to see if those have it, although people aren't usually on those for a prolonged amount of time. Birth control pills, oral contraceptives in women can certainly raise your blood pressure. That's why usually when you get your birth control pill prescription renewed each year, they check your blood pressure, hopefully, to make sure that it's not driving up your blood pressure. The common non-steroidal medications like Aleve, Advil, Motrin, ibuprofen, those can all raise your blood pressure, especially if you take them consistently and frequently or on a daily basis or something like that. Steroids, if you have to be on prednisone for some reason, for chronic lung disease or for an allergy, or if you have a transplant or something like that, steroids like prednisone can certainly raise your blood pressure also. So those are all things that can raise your blood pressure.
Okay. Kind of because it kind of flows with the fact that more and more folks in our society have weight-related issues that causes something called sleep apnea. What is there any correlation with someone who has uncontrolled sleep apnea and how that affects a person's blood pressure?
Yes, definitely. Untreated, uncontrolled sleep apnea definitely raises your blood pressure. It puts a huge amount of work on your heart, stress on your heart, and that pressure builds up, and it is measured in your blood pressure readings. Treating sleep apnea helps to lower your blood pressure. So treating sleep apnea by wearing some kind of a nighttime device like CPAP, or also weight reduction as a treatment for sleep apnea. Both of those things help to control blood pressure.
Okay, good. Yeah, I see one of our viewers is wondering a little bit more about age-related hypertension. Can you speak a little bit more about that, if you would, Dr. Sweeney?
Yep. So as we age, our blood vessels age also, and sometimes they lose what we call their compliance, or their ability to be elastic and expand and contract like they're supposed to. And they become, sometimes calcium gets deposited in our blood vessels. And so we get sort of stiff blood vessels that can't accommodate pressure. And so that drives up the blood pressure. So as we age, that happens. As we age, blood pressure goes up, and the incidence of it goes up. And so we just need to be aware of that. We need to check for it and treat it as best as we can, and treat it aggressively to, hopefully keep that systolic blood pressure, around 140.
Yeah.
The diastolic, around 80, in the 80s, hopefully.
One of the challenges when I have in practice was that, you tried to get around that 140 mark with folks who were older when they were sitting. And then when they stood, you'd have some issues. So that's kind of the art of, it seems like the art of medicine is how hard to push that so people can at least stand and not get dizzy or anything.
Right. Because the problem is the blood pressure medicines open up your blood vessels, but they just make them so they're open all the time. So you're sitting and your blood vessels are open. Normally, when you stand up, your blood vessels sort of clamp down a little bit so that you don't get dizzy. So it keeps your blood centralized and it doesn't flow to your arms and your legs. But when you're on a blood pressure medicine frequently that works by opening up or dilating the blood vessels, you lose that ability to constrict the blood vessels when you stand up. So you become frequently dizzy. You have to instruct patients to, get up slowly when you're getting up from bed, let your feet dangle for, half a minute before you stand up, get up slowly, things like that.
Yeah. Good. All right. So let's go down the path of, you're someone who has tried all you can do to improve your lifestyle. And luck of the draw, you have high blood pressure, just genetically type of thing as well. So it's clear that you need to be on some medication for your blood pressure. From your perspective, what are the first line drugs for high blood pressure, and how do you, as a physician, decide which one of these drugs is the best fit for a particular patient?
Sure. Probably our number one drug right now is what we call an ACE inhibitor, or an angiotensin converting enzyme inhibitor. A good example of that is a medicine called lisinopril, which is very common. It's been on the market for probably 30 years now. It works by that mechanism I just described of inhibiting substances that your body makes that causes your blood vessels to be contracted, so that it opens up your blood vessels, vasodilates them. It is a very good medicine. It's very well tolerated. It lowers the blood pressure. You can start at a fairly low dose, maybe 5 milligrams, maybe 10 milligrams, and increase it all the way to 40 milligrams a day. It's a once a day medicine. It's cheap. Places don't run out of it. It is well tolerated. In some people, it does cause a cough, in which case we usually take people off of it unless they can tolerate the cough okay. But it's a great medicine. It also, in addition to lowering your blood pressure, it also lowers the pressure inside your kidneys, which is a good effect. That helps your kidneys to last longer and to function better. And it also helps your heart too. It helps your heart to relax. It decreases the pressure your heart has to pump against. So it's not only a blood pressure medicine, it's also a medicine for heart disease and for chronic kidney disease also. So that is my number one medicine.
Okay. Yeah. Anything with a prill on the end.
Anything with a prill, right? P-R-I-L. There's probably
All right.
10 different.
Yeah. And then okay. So Dr. McGlone was asking, is there any role these days for hydrochlorothiazide? That's HCTZ.
Yep, absolutely. Hydrochlorothiazide, or its cousin chlorthalidone, which is actually what everybody wants us to use, but for some reason we all use hydrochlorothiazide. It's a mild diuretic. It makes the kidneys not retain so much sodium. It's a very good drug. It's a once a day drug. It's cheap. It's readily available. We frequently, if a patient is on one or two other blood pressure medicines, like an ACE inhibitor, like I just spoke of, or another family of medicines called calcium channel blockers, and their blood pressure is still not controlled, sometimes we add hydrochlorothiazide to that combination, and it really helps to achieve blood pressure control. So yes, definitely hydrochlorothiazide is still very much in our
Yeah. Okay, good.
bag.
I'm sure as a nephrologist that you're seeing folks after people like me have tried lisinopril and hydrochlorothiazide and a calcium channel blocker like amlodipine.
Right.
So, like, what's your approach when you have these patients that are more challenging in terms of trying to get them to that magical 130/80?
Right. It's tough sometimes. Well, we like to make sure that the medicines they're on are at maximal doses. You know, we don't like to give a little of this and a little of that. We like to maximize the dose and maybe even press it a little bit above what might be recommended. So we do that. We do the maneuver that I just mentioned of adding hydrochlorothiazide. Sometimes adding a diuretic really helps to achieve better blood pressure control. Add another drug. You know, there are other, like we said, there's the ACE inhibitors, there's calcium channel blockers, amlodipine, verapamil, diltiazem, that, you know, work very well. Also, they have no effect on the kidney function or on anything else, and they do help the heart as well. And then there's other medicines out there that you know, sometimes you just have to keep adding medicines. You know, some people require 3 or 4 medicines for adequate blood pressure control.
So is your philosophy, you're going to add medications as long as the patient tolerates it?
Yeah.
Until they get to the number for blood pressure that you're shooting for.
Correct. Yes.
Okay. Yeah. Sounds good. Well, since you are a kidney doctor, Dr. Sweeney, we got to throw in a couple specific kidney questions here.
Sure.
So, besides high blood pressure,
Mm-hmm.
What are the other common causes of chronic kidney disease, and what can people do to try to prevent that damage?
Well, the biggest one, especially in our community here, is diabetes. It's terrible. It can be very hard on the kidneys. You know, we want to lower blood pressure with blood pressure medications. We want to control cholesterol with diet and with medicines if it needs it. That's a topic for another Facebook Live event, I think, cholesterol control. And we also want to help to prevent, and then if not able to manage, diabetes. Diabetes is hard on the kidneys. It's the number one cause of having to go on dialysis.
Okay.
We know that controlling blood glucose is important. Controlling blood pressure in diabetes, also important, especially with the medicines I spoke of, the ACE inhibitors, the lisinopril, that helps to preserve kidney function in diabetes. And now we have this new family of medicines, of which Farxiga and Jardiance are members, that have really been shown in some studies to help to protect the kidneys from the bad effects of diabetes. So diabetes and high blood pressure and high cholesterol are our number 1, 2, and 3, or co-number 1 factors in kidney disease.
Okay. All right. And then the second question, because I know you do a lot of work in your team with patients that are have their kidneys have gotten to the point where they're not working and dialysis. So are there any new trends or treatments for patients who receive dialysis these days?
Probably the number 1 trend is to get people to do dialysis at home. You know, everyone's familiar with the dialysis units we have, where you come in and the dialysis is done for you basically by the trained people in the dialysis unit. But there's also what we call home modalities, where we can teach you to do the dialysis yourself at home. We have a very good and comprehensive training program where we teach you how to do it. You do it at home. You can get a little machine that sits next to your bed, and it'll do it at night while you're asleep. There's no needles involved. You don't have to come into the dialysis center 3 times a week. You only come in twice a month for about 20 minutes each time, once to see the nurse and once to see the doctor and dietitian and have your blood drawn and everything. So that is the biggest trend, I would say, is doing dialysis at home.
Okay. One more bonus question to follow up on that. So what would you say, like percentage-wise, of patients are, in the last 5 to 10 years, how has that changed in terms of percentage of patients getting the traditional hemodialysis versus this at-home dialysis?
Our goal is to have at least 25% of our dialysis patients on a home modality, and we are getting very close to that here. We have a very good program in the community here where we can, like I said, teach people how to do the home dialysis, support them. We don't just teach you to do it and then say goodbye. You have 24/7 resources available that you can call, very interactive. At some point, the staff comes to your house to make sure that you're set up right for it and everything. So we are getting, as we call it, penetration in the home dialysis modality.
Okay. Yeah. Good. Well, Dr. Sweeney, thank you. I know you have a busy day to get back to, but I thank you for taking the time to answer a few questions.
Sure. Glad to be available.
I always enjoy seeing Dr. Sweeney when I'm walking around the hospital. He does very good work. So thank you for all you do.
Glad to be there.
All right. Okay, great. So good to have Dr. Sweeney on today. And I have a few announcements to make, some general now. Here we go. So Jason Roberts, Employee of the Month for the month of April. Jason's a plumber here at CGH, and always a smile on his face, always does good work, and great to have him here at CGH. So congratulations to Jason. Looking some new medical staff. Dr. Abdullah Altea has recently joined us. He's a pulmonary doctor, and he started seeing patients about a week ago. And we're really excited about this because he'll be in the clinic seeing patients as well as taking care of patients here in the hospital. And so we'll have a consistent pulmonary doctor in our clinic that if you see Dr. Altea today, you'll see him back in follow up in a few months. And so that'll be nice. That'll be some good continuity that we've been wanting to have. So we're really glad to have Dr. Altea here. Yes. So Dr. Annabita Duden, who is an OBGYN, will be joining us next month. And Barb Tiemann, who's a nurse midwife, will be joining us the month after that. really excited to have those two medical staff. They will be doing deliveries here at CGH. They will be seeing patients here in Sterling and also seeing patients over in our Dixon clinic. So yeah, Dr. Vasantha Gona is here with us now. She is what's called a nocturnist. And so she works with our hospitalist team and takes care of patients at nighttime. So she's here at nighttime and taking care of patients. So you may not see her as much because most people aren't in the hospital at nighttime, but she's here and she does really good work. Yeah, we want to say happy National Volunteer Appreciation Week. That is that in particular our auxiliary volunteers. They do great work and see them all the time doing all kinds of stuff here at the hospital to make CGH a better place for patients and even our staff to come and be cared for. So thank you to them and congratulations. Jewelry sale, must come, must see, a lot of good stuff. And that's going to be happening, looks like 17th and 18th of April. So don't miss that one. And I wanted just to highlight that our next Facebook Live is going to be with, oops, my computer stopped for a second here. There we go. It's going to be April 27th, and it's going to be with Chris Lawson. Chris is heavily involved with our patient information and how we take care of it and approach that with patients. So kind of a little different in that it's not going to be about like today hypertension or some medical related issue, but it's going to be more about what CGH does to make sure that we protect your health information. So Chris will be on to answer your questions and answer some questions I have about that. All right. Well, hey, thank you for taking the time to watch this episode. Share it with those around you who you think might be interested in this. There's a lot of people with high blood pressure, so I would think there'd be a lot of folks who may have some interest in what we talked about today. Until I see you on April 27th, have a good couple of weeks. Looking forward to being here and talking again. Thanks. Bye.